and I'm gonna move on with, you know, as as scheduled. So welcome all. Um, we're gonna get started. Few housekeeping items. Most of you guys already know. Please turn your video on if you're able to, but remain muted during the presentation. We will have a Q&A portion after the presentations, but feel free to drop your questions in the chat box. A reminder that this event is being recorded and will be shared within a week. And I invite you to drop your name and organization or department in the chat box so we can get to know some of the attendees. Hello, and thank you for joining us. My name is Araceli Estrada. I'm a research project manager at the Center for Health Equity Transformation. Our mission is to lift health for all by exposing root causes of health inequities and serving as a hub that pushes boundaries in research, education, workforce development, and community engagement. Today, we are excited to host a former team member, Samuel Mendez. Samuel Mendez is a researcher and artist working at the intersection of health literacy, media studies, and computational social science. Their dissertation is focused on bridging research from these fields into a methodological framework equipped to evaluate public health communication in the pandemic era. Today's presentation is titled AI and Health Literacy Assessments, Preliminary Findings and Health Equity Implications. And with that, Sam, please take it away.
Hi, everybody. I will share my screen really quickly. Oh, yeah, it's really great to be back. I am a fourth-year PhD candidate at the Harvard School of Public Health, and I worked with Dr. Simon and Chicago Check before the era of the Center for Health Equity Transformation. I really carry a lot of the lessons from that time period into the way I want to approach some of these computational and computer-assisted methods. Brief explainer that anytime I'm experimenting with trying to do more health communication and health literacy work on social media, and anytime I do that, I use this digital avatar of myself because this is being recorded, and maybe we'll pull some clips from that too. I wanted to keep that consistent here. And I think it also reflects the fun and positivity and sort of maybe stubborn optimism I have about web technologies and communication technologies. It was a very liberating, technology has often been very much a liberating space for me, I think, especially as I was growing up. And finding communities and peers that were also trying to navigate systemic racism, homophobia, etc. I think it's always been I have a lot of positive associations with new technologies and finding ways to game the system, hack the system in my favor, even if it's on a very small level. So I think that energy probably carries over to my current dissertation work. And as you can see here, this is one branch of it. I will be presenting lessons learned from an ongoing appropriateness test of AI in organizational health literacy research. And I would also like to acknowledge my dissertation committee members, Karen Emmons, Kay Vishwanath, and Sebastian Munoz Nahar, and the assistants Elizabeth Scherer and Zichao Lee, who were also working on this project. So a little bit of background first. I already mentioned fourth year studying social and behavioral sciences at the Harvard School of Public Health. This is a little specific to Harvard, but I have a lot of experience in teaching and researching and training around health literacy methods and how to implement them in more organizational spaces or research workflows. And my work interests are in media, technology, and health equity, and how those things intersect, especially through communication. I will just read this, and hopefully when we come back to this at the end, it will be old news to you. So this presentation is about the lessons learned from a work in progress to integrate AI into organizational health literacy research. Specifically, It uses supervised machine learning to predict CDC Clear Communication Index scores for state public health agencies' pandemic tweets. It includes these main takeaways, which hopefully will make more sense at the end. But using AI in research requires human labor and decision making. It's not necessarily as automatic as it might sound. Using AI for health literacy has the potential benefit of producing large-scale descriptive knowledge and practice-based evidence, which is very much in line with the current strengths of on one hand, health literacy research, but also bridging it with the strengths of quantitative and more computational research. And at the same time, as there are potential benefits, there are definitely potential harms of using AI in terms of propagating health communication inequities. And hopefully that will become clearer as the presentation goes on. So the project is that we're training machine learning models to predict CDC Clear Communication Index scores on state public health agency tweets about COVID-19 in 2020 prior to the emergency authorization of a vaccine. So this process includes single labeling tweets for training data. So the models will quote unquote learn from the scores that trained research assistants have assigned. Double labeling tweets and resolving conflicts for validation data. So the gold standard is using these consensus labels where the two research assistants labeled the same tweets. Where they were the same, we went with that label. Where they were different, I resolved the conflicts and we talked about them. And so after the models are trained, they will be will have accuracy and precision metrics around how well they predict those final consensus scores, and we'll be able to compare them to traditional like inter-rater agreement metrics more common in health literacy. And then finally, interpreting the results in light of appropriateness factors like time, staffing, perceived difficulty, and maybe health equity implications at scale. So that's the overall gist of the project. And I wanted to give you a little bit of context just in case, so we can all get on the same page just about like what some of these words mean. And my specific entryway into this project, I worked on a project called RADx MA, where we were researchers and medical doctors and other professionals at the Harvard School of Public Health and the Harvard Medical School, partnering with community health centers in underserved communities in Massachusetts. This is a graphic that I made in the spring of 2021. One of the aspects of that project was helping to fill communication and information gaps, because there was a lot of info, if you can take yourself back to spring of 2021, a lot of info about testing, masking, vaccination. Policies were changing pretty rapidly compared to maybe the usual pace of public health policies and recommendations changing. And there was a lot of information from the CDC, from the FDA, from state levels, from hospitals, but there were still a lot of information gaps in terms of tailoring that information to the kinds of questions our health center partners regularly fielded from their patients. And right, these patients were often living in multi-generational households, essential workers, at high risk for getting COVID-19 and at high risk for spreading it to others and at higher risk for hospitalization and death. And this was just yet another health inequity layered on top of the others we might be more familiar with and that were pre-existing before the pandemic. And so this policy change and this graphic came after a very intense winter surge of trying to get materials into health centers' hands to answer questions about, can I travel? Can I, see family over the holidays? And just all of the, year-long emotional turmoil of the pandemic. And I bring all this up to say I would have taken any help I could get. And I was trained in health literacy and I was working, I have experience translating complicated information, hopefully into clearer and more streamlined formats. And it was still incredibly difficult working during this time. It was incredibly difficult when policies would change and we didn't necessarily have as much of a warning, at our local level, and trying to figure out how to make the best of a very confusing and very traumatic situation for everyone involved. And so even as we were trying to integrate more health literacy practices and assessments at a small scale in our workflow, it was still very hard. We could do things like a reading grade level pretty easily, but a lot of the more nuanced and rich methods like the CDC Clear Communication Index, we could do maybe on one material, which is still very helpful, but having some information around what those scores might be for the materials we were looking at, like the fact that we could get material from the state or from the CDC, but it wouldn't have any health literacy information or assessments associated with it, meant we also then had to assess before translating and simplifying and streamlining. So that's sort of my personal intro into this, thinking like a tool might be helpful. We wouldn't want to rely on it 100%, but some information would be a better start than the zero we kind of had at this emergency communication time. And so this project aims to address the resource intensive nature of these health literacy assessments and supplement that resource intensive approach, not replace it, and hopefully contribute some additional bits and pieces of knowledge to the health literacy literature. So because the current health literacy assessments operate closer to like a qualitative assessment, even though they have scores, you'll often see research that uses purposive samples of materials through more of a qualitative sampling approach, which is different from like a quantitative sampling approach. And then the findings are often in the form of qualitative themes and design principles that can help people trying to do health communication take some usable pieces of knowledge, and it contributes to often usable and transferable knowledge. And that's why I'm really drawn to the field of health literacy, is it's very action oriented, it's very usable, and at the same time, these are the current strengths, and I think there's room for computational methods to supplement those strengths. So through computational methods, we can work with an enumerated corpus, which means I don't have to take a sample of all of the social media posts. As long as I have that data, I can just use all of them over the course of a year, 5 years, 10 years, and draw some broad strokes descriptive knowledge from it in the form of quantitative data that a lot of people in public health are familiar and working with, and that can help target maybe policy decisions around how many more resources. How can we make some argument for more resources for communication at the state level, at the local level? And generalizable knowledge, right? What's missing right now from the field of health literacy is like there's a general sense that a lot of people share around the need to improve health communication in the wake of the pandemic. What does that mean? How far off was it? Was it actually as far off from existing guidelines as we feel it is because we were there in the thick of it? These are questions that I do believe there's room for computational methods to address while making room and resources for some of the more resource intensive ways of doing health literacy work. So this project uses supervised machine learning, and the way I describe it is it's basically a way of training a computer model to predict human labels on data. In this case, those human labels are health literacy assessment scores. So the CDC Clear Communication Index, you'll rate yes or no, does it meet this guideline? And that rating of yes or no is what I'm hoping to predict. So the supervised aspect of it means we're using human labeled data to train models. So that refers to having researchers score and assess tweets, and those scores form the training data. And then the machine learning is using algorithms to detect patterns with few statistical or causal assumptions, right? So there would be a way we could approach this work where if we had specific hypotheses of what kinds of words or what kinds of sentence structures led to a clear communication guideline being met, we could use that. But I think when we're in this exploratory phase of what does it look like to meet those guidelines or not at a large scale, machine learning, I think, is a helpful way to get at that prediction and to be able to find out what are some of these features that we might want to focus on. And so this work relies a lot on the CDC Clear Communication Index, which is a tool debuted from 2014, last updated a couple of years ago. So it's relatively new in the grand scheme of established health literacy assessments. It has a few key features that make it well suited for machine learning. And so one is the format flexibility. Unlike others that were designed for print materials or for specific formats, the CDC Clear Communication Index is meant to be flexible enough to handle multimedia and online communication, right? Which can involve text, which can involve video, pictures. Although for this project, I'm just focusing on text for right now as an exploratory study. It has binary scores, which are very helpful for working with computers. Um, there's a rich qualitative element through the discussion around why something doesn't meet a guideline or how it could, but it is simplified enough to have binary scores at the end, like it's either a yes or a no. You're not rating how well it met a guideline, you're just rating did it meet a guideline or not, which is, again, very useful for working with computers, where with this quantitative approach, you kind of have to lose a certain amount of that nuance. And then it's in distinct sections, so the questions aren't really dependent upon each other, which means I can fine tune models per each question. And maybe if it works on one and doesn't work on the other, that's a great finding. We can know, okay, if we want to pursue this approach further, focus our energy where it will be best used. And then a quick note, right? These scores indicate if guidelines are met, not how well. So just because you get a perfect score on the index doesn't mean your communication is perfect. And these are examples of some of the questions we used from the manual. So one question was, does the material contain one main message statement? And for a tweet, right, we had a lot of discussions about what that meant for a short text, about what that meant for COVID-19. As one example, a tweet that just shared, here are today's COVID statistics, right? That was a very common message sent out in 2020. If it didn't have any so a main message would provide context or interpretation help for those numbers of like, COVID is dangerous and here's how dangerous, right? That might be an example of a main message statement. Or COVID-19 has been increasing in our state over the entire month. And that kind of help with interpretation, we qualified as a main message statement as one example. Does the material include one or more behavioral recommendations for the primary audience? So something like wearing a mask in public would qualify as a yes for that. And then a couple of the questions were these follow-ups, which I have been analyzing as categorical variables. But so this one is, does the material explain why the behavioral recommendation is important to the primary audience? So as an example, you might say, right, it's important to mask in public because XYZ, and that explanation of why. And a note here is that we applied some of these to all the tweets, regardless of length. So even though this one says you might not necessarily apply it to tweets, we thought it was important to be able to see if it's applicable at scale. And especially as we were focused on pandemic communication, we think even just the process of trying to apply this tool at scale is causing us to rethink, well, maybe we should have that standard for more communication in short form online, because that might be the only thing someone reads. And what does it mean if we're using social media as a primary way of sharing some of this risk information with journalists, with, et cetera? So the research project itself, we use the modified CDC index, which is a short form that the CDC has released a separate manual for. We used 3 of the sections, the core section, which includes things like main message and call to action, a section around behavioral recommendations, and a section around discussions of risk. We made modifications to some of the questions based on the research goals in the process. So for example, we changed a question to, does the tweet always use active voice, instead of does the main message use active voice, as a way to simplify and streamline that process a bit. And like I mentioned before, we applied questions to all of the tweets regardless of length. And we are using supervised machine learning to see if we can predict the labels on tweets that the models are not being trained on. So that involves applying the CDC index to around 1,900 tweets single coded for training data, and then around 300 tweets, 2 people labeling them each for validation data to assess how well does it perform in predicting labels on this data set that it hasn't seen before. And a way to assess the performance in this sort of appropriateness phase is I'm using a term frequency approach, which will use sort of regression and find what are the most predictive single words that predict whether or not a tweet meets a guideline. And I'll talk about that in a bit. And then the one I won't talk about in this presentation is using a BERT-based approach, which is a little more complicated and relies on words in context and networks together. which can usually lead to better predictive scores, like prediction of the scores. But term frequency is a nice way to explore the data and also is easy to interpret the findings in ways that align with other health literacy best practices, as you'll see momentarily. So this term frequency analysis approach, I'm using lasso regression, which is often used in machine learning to find features that might predict scores. I'm treating the tweets as bag of words for that approach specifically, which means, as shown on this screen here, you turn the entire body of documents we're looking at, these tweets. So you'll have a very large matrix that for most rows is mostly zeros, because that matrix has every single word that appears in the data set. And then each tweet, you'll have a numerical representation of hi appears twice, world appears once, sun appears 0 times, and you do that for every single tweet. And so it's regression using the lasso approach of trying to minimize the number of variables. So as opposed to the thousands of individual words, trying to minimize it down to a manageable set that actually predicts the scores. And so before I get to the results of the preliminary analysis, I think the process itself sheds a lot of light already for what it might mean to try to use a computational approach in organizational health literacy work. So the coding process was pretty simple. I think it did not take especially because we were focused on one topic of just COVID-19. Coding 75 to 125 tweets per week per person was very doable after training and after aligning for a couple of weeks on how to apply some of the questions. The research assistants that were especially working on this found like these weekly benchmarks to be helpful. And if we were to do this at a larger scale or in a more robust professional setting with investment, let's say from a state agency or from the CDC, this is a helpful structure that we could reuse. There were a lot of challenging points in aligning on some of the questions for this data set though. So for example, the questions around language were actually really hard. So like if the tweet used passive voice or if the words were ones the primary audience used, were very hard for raters to agree on, had low inter-rater agreement compared to the other questions that relied on more public health communication specific training and knowledge. So on one hand, that's promising. And on the other hand, it also maybe is a pointer that it might not be worth trying to get people in public health to become the experts on like grammar and language use. And maybe that's where we would want to bring in experts from those fields. And that's where community engagement would also really help in making some of those decisions around, are these words common? Or we might use another approach altogether or not use a computational approach for this. And then social media itself also brought its own challenges for thinking about health literacy. So for example, can a hashtag count as a call to action or a behavioral recommendation? We had to have a lot of discussions like that when there are often short forms of communication used, incomplete sentences, bulleted lists that are only kind of bulleted lists because the formatting isn't technically correct. So we also had a lot of those decision-making processes that are baked into our models because they're baked into our training data. And that would be really important to highlight and document and put up for scrutiny if we were doing this in an official like government or research capacity and we were trying to make bigger claims with these findings. So what have we learned so far? As I mentioned, there's varying appropriateness of the questions at scale, varying difficulty in applying different questions to this data set. And the results so far, there's varying inter-rater agreement across the questions and varying level of data imbalance. So this is another key issue for training models. We found relatively very few tweets that actually discussed the nature of the risk they were describing. And so that means there is not a lot of variation or examples for a model to learn from, which is going to be pretty problematic if we wanted to apply it to other data sets or like a broader scale. It's probably not going to be a reliable model compared to the more balanced data around whether or not something included a call to action. So, that split was maybe like 66% included a call to action and a third didn't, which again highlights some of the tensions of using computational methods of like ideally we would probably want to see very imbalanced data, like pretty much everything has a call to action because that's a pretty like standard health literacy guideline. But the fact that it doesn't does mean that we can learn a bit more about how, like what it looks like when a state health agency doesn't include a call to action. So there's a positive and negative even just built into the method there, that the data already has to kind of look not ideal for us to have enough to work with to train a model on. Whereas we saw that in the extreme, the opposite direction with discussion of the nature of risk, where so few tweets discussed it, which is a problem we would want to identify and fix in practice of public health communication, but also a problem for our data training. So our model probably won't be reliable for that question. And the preliminary results, so I'll share the findings from the lasso regression for a few of the questions to show some of the health equity and practice implications. So for the question, does the material include one or more calls to action for the primary audience? I will be showing the top 7 positively correlated words with like a yes. So for tweets that do include one or more calls to action, don't take these beta coefficients at face value. It's preliminary, and lasso regression normalizes it a bit and biases it towards 0. But we can see sort of a general reality check that this checks out, that words associated with a yes for a call to action are these action words like visit, read, learn, watch, find, your, check. And these are relatively high associations compared to a lot of the other words. And so, all right, if we were to, let's say these were not as preliminary findings, these could translate into health literacy guidelines, one of a list of examples of the kinds of verbs to include for a call to action, right? And that's already a helpful starting point for someone writing a tweet in a public health emergency situation of, oh yeah, we do, then there's still questions about like, do we actually want people to be visiting and reading and learning, or do we want more action-oriented calls to action as opposed to these like self-education ones? Because a very common call to action was learn more at our website, visit our website, watch this video, and it's worth questioning that. And the top 7 negatively correlated words show some of the potential issues of using this approach. So we see things like Newton Health, that account, it's a town in, I believe that's one in Massachusetts, New Hampshire Public Health, hashtag, Pennsylvania's. And so what we wouldn't want to see happen is, let's say, the Massachusetts Department of Public Health, in addressing Newton, often did not include a call to action. We wouldn't want to have that association in the model of like, oh, if they're mentioning Newton, they're not putting a call to action, right? That maybe does reflect the reality of what the situation was in practice, but we wouldn't want to bake that into our model for scoring purposes. If we wanted to say we can apply such a model to tweets to tell you if there's something you need to edit. But it is a helpful piece of descriptive information that we're able to see some of these patterns play out statistically, that like, let's say Pennsylvania, New Hampshire, and Newton, Massachusetts, that might point us to maybe a point of training or investment or an intervention point in health communication. Similarly, does the material always use words the primary audience uses? So this one, I think, shows the difficulty we had in training this model, even preliminarily. So there weren't even 7 words that we could find that had a positive correlation with this. So they're like very low predictive power in the model. Your and you are such common words. We wouldn't want to use those anyway. Stay home might be helpful in some sense descriptively, but I think the main thing I'm drawing from this, right, out of thousands of words, we couldn't even find 4 meaningful ones that can predict the positive score here. This is preliminary data, but I think that points to the overall difficulty we had in coding this question and in trying to make a model for it, because it's makes less sense when we're thinking about a state level of communication. What are words common across the state? If we wanted to use a computational approach, maybe we would just have a list of the most common words on like a simplified English version of Wikipedia or something, and then see what percentage of the words align with that. But the negatively correlated words are a little more interesting and are these complicated words that we probably would want to use synonyms for or rephrase, right? Like operational, certificate, strategies, findings, data. That aligns with how the discussions we were having with coding about like there are simpler ways to put some of these ideas. And the audience sometimes seems to be maybe public health professionals, even though they're on this very public platform and not stating that. So there might still be some use in modeling this and maybe for a descriptive purpose about what it looked like in this data set, not necessarily to predict scores. And then finally, one more slide here with with preliminary findings from this term frequency approach. Does the material present information about risk? So the top 7 words associated with a yes are spread, risk, high risk, stop the spread, drugs, prevent, and then China. So I wanted to bring this up, right? Because some of these we would say make a lot of sense just on face value. It makes sense that if you're using the word risk or high risk, you're probably presenting information about risk. If you're using stop the spread, a lot of times that was presented with information about risk. But then we also can see the potential to further stigma if we were to bake this into a model by saying, oh, anytime someone is talking about China, they're talking about risk. And that's not the kind of thing we would want to bake into a model to tell you to edit your tweets, to talk about risk specifically in this way. And then again, it also provides some hints of like important descriptive data that is also missing at scale, right? Of like, what role did public health agencies play in furthering anti-Asian sentiment and in furthering xenophobic sentiment and anti-Asian racism around the pandemic? That's a very worthwhile question. That's not, the study was not designed to really tease that out, but seeing this here alongside words like risk and high risk and in the same level of predictive ability should start to make us question what are ways we can intervene in that still today, and also with whatever the next health emergency is. And in terms of a practical approach, that might be something like we can delete words from the model, or that might also prompt us to rethink like maybe risk is not something we want to automate discussions of because the potential harm is a lot greater than, let's say, a call to action automation around that kind of guideline. So and some food for thought that this project is already raising. And then negatively correlated words. So does the material present information about risk? No. We can see the CDC username. We can see a specific user being referenced, responsibility. So maybe not the most helpful preliminarily face value, but I think we can, again, start to see like the CDC popping up there is making, again, me want to look into what did that look like in the actual numbers around this? What was the CDC messaging that maybe didn't include information about risk that then people were sharing? So, I think there's a value in this high level descriptive data, even if it doesn't, we might not want to translate it into a model to predict scores. Being able to look at this data at this very high level over the course of a year of the pandemic across every single state reveals some useful high-level knowledge that should make us question, like, what is the role of health communication and how do these different pieces interact and how do we not reproduce stigma and communication inequities? So those are the preliminary findings and some key takeaways. So from the process is that the process of labeling wasn't that hard, and we're not working with a huge data set, right? I think the training a model off of 1900 tweets is pretty small in the machine learning world. I think pretty big in the health literacy world. And trying to apply these methods to a data set of like 50,000 tweets, right? Pretty small in the computational world, pretty big in the health communication world. And so I think showing that the actual process of labeling this many tweets wasn't that hard, and maybe there's more opportunity for more traditional methods to try to get at some of this scale. And then also that if we do want to, the bottleneck isn't going to be data labeling. The bottleneck might be these other questions of really important health equity concerns or of how well the models perform. The actual data labeling for something as short as a tweet is not the hurdle here. The other takeaway is that the process like really needs community engagement, right? I think for this like appropriateness check and to like iron out some of the wrinkles of the workflow, I think it's fine that this is largely, that these are like students like myself and master students largely working and providing the labels. But we, whatever the next step is, I think it's very important to have community engagement so we don't just have people trained in health communication assessing the tweets. We also have community health workers. We also have nurses and care providers. We have patient advocates and people with various relationships to like English and medical information. So that's an important takeaway. That is definitely a super important next step if we ever want to pursue these methods further or even follow up on some of the interesting points that are coming up just as a descriptive data point. And another process point is that data access is the biggest challenge. So I'm able to do this work because I had access to the Twitter API back when that existed for academic purposes. This would not be feasible now, right? It would cost like thousands and thousands of dollars, whereas it was free when I did this. And that's a huge hurdle. And it's also something I am really uncomfortable with, that I want to see more like legal and political advocacy around. Why should we have to pay a social media company thousands of dollars to access publicly funded communications? That does not sit right with me. And it's a big barrier to this important public health communication knowledge that allows us to get a sense of like, how do we improve online communication? How do we tailor it more? If we can't have access to that data in the systematic way, that's going to be a big problem. And I think that's a really important policy need as we're rethinking our collective relationship to these social media companies. And then, the pandemic's prolonged nature and the large scale of social media should prompt us to rethink about what organizational health literacy involves, right? So even one small example that maybe social media short posts don't need to include a discussion of why a behavioral recommendation is important or what the nature of the risk you're avoiding is. Does that make as much sense in the pandemic era when we saw how important online communication was to get updates in real time, maybe not to general publics, but at least to journalists and other professional audiences that then pass that information on, or at least try to. And what does organizational health literacy involve when maybe we can't keep up with the pace of mis and disinformation online? Like, what is a more networked approach that is not just relying on a single expert? And I do think these computational methods can help us understand what the situation currently looks like to try to answer what do we want it to look like. And then in terms of the preliminary like quantitative findings, some CDC index show more promise for a machine learning approach. So the main message and call to action and behavioral recommendation questions in particular, whereas some of the language around like word use, passive voice, discussions of risk were harder with this data set. Gaps in communication practice and are barriers to health equity and computational methods. So, right, the nature of the risk, right, is a key assessment question that can get at, are you addressing communities that are more at risk, or are you addressing communities that are facing health inequities? And I think it is a big deal that there was not a ton of data to train a model on that described that. And right, this is from 2020. We can think about how that maybe got better over time, but right, that's a sense. That's not necessarily, we can point to any data to say that. And so not only is that a health communication inequity of like providing context and information for the COVID-19 inequities that we saw in 2020, it's also then going to impact our ability to assess these tweets along that line at scale. So it's has these ripple effects that are also going to impact our ability to research what does good communication around that look like, and we'll have to use other approaches that aren't computational, probably. And then stigma and health equity concerns must be part of our concept of appropriateness around like health literacy and health communication. If we are going to propagate potential health and racism and other related stigmas, that's not something we should invest in. We should try to invest in things that will work against that. And so, right, we can think about, does that mean we just don't use these types of methods for some kinds of health topics? Maybe. I think it's worth considering. Does that mean we try to invest a lot in health, like community-based organizations and patient advocates that are communicating in more equitable ways already, and then we can learn from them? Right? I think there's a lot of creativity needed to think about how do we intervene in health communication, and that you can still tie that to computational methods to get some of the benefits of those methods. So in summary, hopefully this sounds more familiar than it did at the beginning, but this presentation is about the lessons learned from a work in progress to integrate AI into organizational health literacy research. Specifically, this project used supervised machine learning to predict CDC Clear Communication Index scores for state public health agencies' pandemic tweets, and includes these main takeaways. Using AI in research requires human labor and decision-making. Hopefully, I communicated that in all of the tensions and conversations we had around applying the method. Using AI for health literacy has the potential benefit of producing large-scale descriptive knowledge and practice-based evidence, right? There's a real way to train models based off of what we would like to see more of, which might be the next approach for something if we think it's worth continuing this with like behavioral recommendations or calls to action. And is providing data that we don't have around just what did COVID communication look like at a state level across the entire country for the first year of the pandemic, right? That's not a question we really have the answers to without methods like this, or quantitative methods, not necessarily machine learning. And then at the same time, using AI for health literacy has the potential harm of propagating health communication inequities that can include just getting more efficient at reproducing the kinds of messages we see, which might reproduce stigma, which might target more educated or wealthier people, which might not address health inequities. If we're trying to make that process more efficient, then are we also making health communication inequities faster, better, stronger? So thank you. I'd like to say that this work is possible through the support of the National Cancer Institute. And you can find me on Blue Sky and YouTube at Samuel Animates, and I have a health literacy newsletter out now, where I'm also trying to translate some of this work there. So I will gladly answer any questions, provide any points of clarification, and thank you for your time.
Thank you, Sam. I think we can start dropping questions in the chat if you have any, or raise your hand since we're a smaller group.
Okay.
I see.
Yeah. Well, if
Yeah,
it's in
I
the
see.
chat, I'll get to it. Can I start now?
Yes, go for it.
Okay, cool. Cool. So from Megan, I was curious whether your findings say anything about the use of slang or vernacular English in health communication by state agencies. I would say so far, no. We did some preliminary data exploration, and in the coding process, I would say slang or vernacular English was not really a common mode of communication by state health agencies, which is, I don't know that that's one way or the other, good or bad. I do think that that does signal the need for further adaptation from what the state is saying if you're going to work at a local level, or talk to people one-on-one. But yeah, I don't know that there's necessarily like a consensus or that we've seen any best practice or anything that we want to recreate around like a state trying to do that. So I'll say the finding so far is that that's not really happening. Where I do see maybe things specific to social media is that like hashtags are very common, and the way those interact with the body of a tweet is not necessarily part of health literacy research right now. Emojis are very common, and we saw right like one emoji of like the cross arms yes no face um, in some of the results so far. Bulleted lists using emojis were really common. Um, I did not see them in a way where they seem to carry a lot of information. So I think right in these are preliminary findings. I would refine the data set maybe to just exclude emojis because they don't seem to be used in an informational way, more so in maybe a affective or decorational way. But those are right, these are key decisions that will impact the findings. And so again, these are very human decisions made from particular viewpoints. Just because there is a computational aspect to it doesn't mean it's like objective. Um, thanks for the feedback and the question, and let me know if I need to add any other info there. From Laura, are there potential applications of your text-based methodology to other popular social media modalities that aren't text-based? Yeah, so I think that's one trick that is often used in health literacy assessments, is that you might use like the transcript of a video to put it into a text format, because there are, for example, the PMAT AV is meant for video assessments, but a lot of even the CDC index, right, relates to the textual content or the spoken content. There might be a way that you can like integrate that with the images as well, but um, it would be very feasible to apply this to like short form videos, and especially like a TikTok or a YouTube short. So I do think there's um, a lot of room through this to show, at least maybe for something like a main message and a call to action, that might be worth trying to make a tool that can work across social media platforms. And then there are also, right, I was focusing on text as it's sort of the most straightforward and still a very prominent way of communication in public health. There are also other, it might be worth also experimenting with using like machine vision also to try to interpret some of the visual information for these ratings as well. But yeah, I think I really like that idea of applying it to other social media formats. And I think the results so far show that it might be promising for some kinds of questions. Cool. Thank you for the question. And then we have from Dr. Simon. I'm wondering if the approach to health literacy changes with respect to language. Yeah, especially when it's language with characters. Yeah, so I think that's a big question, and I think shows another sort of aspect of systemic inequity is that a lot of the health literacy research that's out there is focused on English. So there definitely are specific scales made for specific languages. I've seen a also adaptation of like the CDC Clear Communication Index for Brazilian Portuguese. I haven't seen one for Chinese. I think the general approach for the CDC index for some of the questions might be that you can just answer the question based off of the content in Chinese for the questions that don't focus on language use. So, for example, is there a main message? Is there a discussion of risk? Is there an explanation of why a behavioral recommendation is important? One approach I've seen is that you can take some of those questions to be like language agnostic. That's probably debatable. I would not say I'm an expert in like the translation of those tools, but definitely the ones that require a lot more translation and validation in particular languages and communities are some of the more language-based questions. And so I think, yeah, there's a lot of health literacy research in Chinese, but there's not the same amount of like, let's say like CDC funded tools that are assessed and validated in Chinese, right? They tend to focus on English, and that's a systemic barrier considering there are a lot of Chinese speakers that we would want to reach. So yeah. Cool. And then we have from Robbie, what do you recommend to use more lay terms when physician scientists are communicating personally? Yeah, so I think there's a lot of tools that are available. Um, the CDC and a few other agencies have some plain language thesaurus resources that I find very helpful. They don't cover every single word, but I think they are a helpful start to edit some of your words. And that's the kind of thing that we could easily. I have seen people working on tools like that of taking those thesauruses, identifying when those words are in a text, and telling you, here's a synonym in this thesaurus from the CDC, for example, or from the NIAID. Um, and then the other approach is through like some there's other assessments as well. Like I think the smog is a readability assessment that I find helpful, that at least prompts you to, anytime you have a word more than two syllables, like try to rephrase the sentence so you don't have to use that. Um, that's a common shorthand I like to tell people, is that if it's over two syllables, really consider whether you need it. And for example, even saying vaccine instead of vaccination just makes it like easier to read and sound out. But I think it's will be very context specific. And that's another case where I think working with right health literacy training is incredibly helpful. And so is like direct experience doing community outreach. And so I think if there is, that's where I would want to see like more investment in community health workers and patient navigators and those kinds of roles where um, there's so much knowledge you gain from interacting with people who are trying to interact with the health system um, that should be a source of like practice-based evidence, as I'm liking to refer to it, of if we want to reproduce or promote some of the practices people are gaining from helping people navigate the system. I think that's like a great place to start. And if that can be baked into some of these assessment methods or some of the training for descriptive models, even if not predictive, I think that would be a super helpful route of like going to some of the experts in how to talk with your specific community. Oh,
That was
okay.
so many questions in the chat. Um, any other questions? Um, Something that came to mind is I know you mentioned uh, a lot of stigma in some of these AI models.
Mhm.
What are some things that maybe centers like ours or public health departments could be doing or supporting or advocating to kind of fight some of the
Yeah.
racism and stigma in these models that may not be intentional, but um,
Yeah.
sometimes the folks that work on them don't represent like our communities.
Yeah. And I think that's something I struggle with a lot, right? Because I think I opened this by talking about, I think, my own like stubborn optimism in like communication technologies. And understandably, though, I think I try to keep that with a critical eye. Um, and understandably, though, I think there's a lot of resistance to the use of these kinds of tools. And I think if there's a way that you can even um, bring that resistance into spaces where this research is being done, right? I think, for example, like I'm incredibly uncomfortable with the idea of applying a health literacy assessment to like a patient or a community member, but I think there's a lot of room for it as a tool of accountability for like the government and like tracking how our agencies are serving or not serving people. Um, but right, that would be, I could totally see a lot of fair arguments that even that is not going to be that great. And so I think um, the disconnect I think can come from the fact that I'd say I'm relatively connected to the to some of the people that are writing and creating these messages, right? I've done that myself. Also, like partnering with community health centers and community-based organizations and various research projects. But I think, right, that's a strength of public health, not necessarily a strength within machine learning or computer science or some of the other fields that are interested in these methods. So I think whatever bridges we can make between public health and a lot of these other fields, right, that's easier said than done. But I think about how, um, right, there's already more and more generative AI in like Microsoft Outlook and Microsoft Word and Google Docs and our email platforms. And those aren't necessarily being developed with like health equity or even, health literacy, plain language in mind, uh, much less these concerns around like stigma and that kind of thing. So I think, easier said than done, but I think anytime we can bring these concerns into the room, I don't know if that means, I think the Center for Health Equity Transformation is like a useful model of being able to bring in these concerns to other kinds of research projects. But I think there's a way that so much of this is happening, right? Like the Microsoft examples, right? That's not publicly funded research that we can like intervene in and critique in the same way as a publicly funded research, because so much of it is behind closed doors. Some of the details are hidden, and then you see the end product and you have no idea what went into it. And then you're finding out the problems as you go because it wasn't necessarily built with public health or health equity in mind. So, that's not a super concrete answer, but I think any ways to connect with people in industry as well as the people on the academic side of this research, like the more connections, the more bringing this resistance and the need to slow down, the better wherever possible.
Thank you. We might have time for one more. We're close to the end of the hour. Any final comments or questions? If not, this was such a pleasure to see what you've been working on, Sam. We would love to have you join us in chat for longer. Um, but for those that are, joining us and haven't heard of the Center for Health Equity Transformation, please visit our website and sign up to our newsletter. We will send a follow-up email with the event recording and some additional details for upcoming events at Chat and ways that you can get involved. And we also have a podcast. So if you're interested in that, please visit our website and stay connected. But with that, thank you again, Sam, for joining us and for everyone who attended and participated and asked a question.
Thanks so much for having me.